Oh, morning, Catherine. I think you're on mute.
Good morning.
Sorry about that. Morning, everyone. Hi.
Hi. Let me just, first things first, try and make you both co-hosts.
Very
I've not
good.
used Zoom for a very long time, actually. It's normally Teams now, so let me see.
It is, isn't it? Yes,
Make
yes.
co-host. Yes, you might get a notification.
Okay.
Make co-host, yes.
And we can presumably, Dawn, we can each share our screen, can we?
Oh wait, yeah, no, it's logged me in as Dawn when I'm Rachel.
Oh, I'm sorry. I thought Rachel. Yes, I do apologize. Yes, you're up as Dawn. You're up as Dawn, but it's obviously Rachel.
Yeah, it's because Dawn set this up, so I'm using her logins. I didn't realize that. I'm glad you made that mistake. Yeah, so we've got some people in the waiting room. So we all okay. We'll got 41 people booked on. So obviously not everybody who books turns up, do they? So we'll be expecting about 30 people, I think, coming in. So it's a decent.
Very good.
I'm just going to say a few opening lines, and after that, I'll just hand out. Who's doing the first presentation? Catherine, you're doing the first presentation, aren't you?
Yes.
I'll hand over to you to introduce yourself, if that's okay. Yeah. Did we say we were taking Q&A straight after your? We're taking Q&A straight after your presentation, Catherine, because that's the overarching sort of what is the, how is the ICS getting on bit, and then we go to the engagement part.
Yeah, and I have I will say, but the slides I circulate, there's a sort of more detailed appendix that I don't use, but it's for people to have afterwards, and therefore I have a slide I stop at that says questions.
Yeah, brilliant. And I'll just keep my eye on what's the questions that are coming in on the chat, yeah, try and coordinate the questions and answers as best possible. Okay, there's 10 people in the room now, so I shall start letting people in, otherwise we might lose some. There we go. Morning, everyone. Morning. We're expecting about 30 people on this webinar this morning, so we're just going to let people join over the next couple of minutes because we've only just hit 10 o'clock. I think this, I think Zoom is putting everybody on mute as you join, but just as a reminder, if you could keep muted while you're not talking. Thank you. Just to let you know, I'll do another reminder before we kickstart that this is being recorded so that we can edit the session and put a version of this on our website. So turn your cameras off if you're not happy with being recorded. Hello to those of you that have just joined in the last couple of minutes, and we'll get kick-started in a moment. You're just waiting for the last few people to join in on this call. Great, we've got quite a lot of people in the room. I'll just keep admitting people as we go along, so I think we can get started today. Welcome everybody, and thank you very much for coming to this webinar this morning, which is around engagement with the ICS in Bob. I'm a great believer in a big part of what the voluntary sector do and the success of what the voluntary sector do is dependent on how we engage with other stakeholders who have the same or similar priorities to us. So whether that be health or the local authority or wider stakeholders. So this makes today's event ever important to our successes moving forward as a voluntary sector across Bob. And today we're going to listen to two presentations, one from Catherine Mountford around the developments of the ICS so far and to date, and then John Underwood is going to talk to us about the proposed engagement strategy of the ICS and how the ICS are going to go about developing that engagement strategy. I think it's a really exciting event because again, our successes are really reliant on having a structured and effective mechanism and approach to engaging with health and the ICS across Bob. And today is sort of starting that process. I think good engagement and good communication is leads to really positive outcomes for people in communities, and that streamlining and communication across different stakeholders is a key to successful services. So without further ado, I'm going to hand you over to Catherine Mountford, who works for the ICS, to start with her presentation. Thank you, Catherine.
Thank you, Rachel, and thank you everybody for inviting me. So I'm Catherine Mountford and I am the Director of Governance for Oxfordshire Clinical Commissioning Group, and in that role also lead on communications and engagement. And for Bob ICS, I've been leading on the developing the governance for the new system, and also working with John, who will introduce himself, on thinking about how we develop and improve our approach to communications and engagement. So as Rachel said, I'm going to give you a quite short presentation probably also quite dry and a bit related to the structures that we are required to develop. But also I'd like to reiterate, one, we're very early days, and two, that this only shows a very small part of the structure, and I'll explain why as I go through the presentation. So I'm just going to share my screen. Has that come up? Brilliant.
Yeah, perfect.
Okay, so as it says, developing our integrated care system, I'm going to run you quite quickly through the context we're working in, what's the purpose of the ICS, key components and terminology, and please do haul me up if I get too much into the NHS alphabety spaghetti of acronyms in there and try to explain it. The real importance of system and place in our geography, some of the bits about governance, the partnership structure, and then just a little bit on where we are now in comms and engagement, which John will pick up more of in his presentation. So firstly, a reminder that the bill is currently going through Parliament. So everything we're being asked to do is subject to legislation and subject to not infrequent changes as amendments get laid down and the discussions continue. Not expected that the Act will receive royal assent until towards the end of March, which has partly been what's fed into a change in the implementation date to the beginning of July. What we are getting alongside this is significant guidance from NHS England based on that draft legislation. So again, that gets updated as things change. And also just to highlight that within the NHS, NHS England is given power by the primary legislation to issue us with mandatory guidance. So we are then required to work to that. So as I said, this is aims to put us on a statutory footing for July 2022, changed from April. But we need to remember that is setting up new organisations, new ways of working. So it's very much, that's the start of that new system, but we need to evolve into a fully functioning organisation and system. And that absolutely needs to occur in dialogue with our partners in the widest sense, including, as Rachel said, our voluntary and community services partners. And part of the key roles of that will be developing a system strategy with our partners, broader stakeholders and the public over that first 12 to 18 months. The purpose of an ICS, these are not new. These were set out in the NHS long-term plan a few years ago. And in the NHS part of the world, it's how we're being organised and the statutory bodies to deliver that's changing. So again, in terms of common purpose, what are we here for? The goals of the ICS are to improve the outcomes for our population in their health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for many. So ensuring the system partners, we are spending public money to best effect for our population, and then a role in the NHS supporting broader social and economic development. And this is where the NHS love of three-letter acronym starts. So there are different elements to the system. So the integrated care system is at Buckinghamshire, Oxfordshire and Berkshire West level. There were no changes proposed to the geography we've been working together in over the last few years. And the integrated care system is that wider partnership of trust, and these are just some examples: the trusts, the practices and primary care networks, the local authorities, health watches, our voluntary and community sector partners, the academic health science network. So that's the ICS, everything within that blue box. The integrated care partnership is will be a statutory committee, so it is in the legislation that is a joint committee between the Integrated Care Board and the local authorities that provide social care services, so 5 local authorities in the BOB area, and that has the core role. It's a partnership committee. Need to think about the membership and the wider engagement in that committee to set the overarching strategy for the BOB area. The statutory NHS bodies I've referred to a couple of times within the area will be called the Integrated Care Board. It's an NHS statutory body, so subject to NHS guidance, as I've also talked about. And then to add to the confusion, it then has a board. So it has the unitary board of that organisation. So like the trusts have boards and the clinical commissioning groups have had boards or governing bodies, it's required to have a board to deliver on those statutory duties. But then the team, so the rectangular box that says ICB team, that in the first instance will be made up from all of the current clinical commissioning staff who will transfer into the Integrated Care Board, as the clinical commissioning groups will no longer exist as of the beginning of July. And another important element within the guidance and the legislation is place-based partnerships. So where it makes sense to do things at a place level, so Oxfordshire, Buckinghamshire, Berkshire West, because we have communities we work with, local authorities we work with, provider trusts we work with for that local population. And then taking that a little bit further in terms of system and place within the geography of Buckinghamshire, Oxfordshire and Berkshire West, we do feel, and this is from an NHS perspective, and I'll talk a little bit about our local authority partners, we are a system made of 3 places. We don't have the single focal points that many of our other southeast, particularly ICSs have, who are a single county or built or around a single acute hospital. So for example, the Frimley ICS area is very much about the population who use the Frimley services. And we think, well, no, so on the 1st of July, people accessing care will do it in exactly the same way as they did it on the 30th of June, either through their local GP practices or their local services at the local hospitals. And most of that care delivery and improvement will need to be managed at place. So the overarching system at Bob level should be thinking about the overall system strategy, but using the principle of subsidiarity, delegating things to the appropriate level to do it. So some examples here that we've given, and it's not fully comprehensive, is there are pooled budgets in Buckinghamshire and Oxfordshire. They should still be managed at place level. A lot of the work around urgent and emergency care, so supporting our population to access that urgent care when they need it, either through primary care, ambulances, the hospitals, needs to be managed at place. Supporting people with long-term conditions needs to be managed at place. And also, if we take it further, there are some things that get managed at practice level, primary care network level, working with in Oxfordshire, district authority levels, in Berkshire West with one of the 3 unitaries, because there are different needs in those different populations, and particularly where we have that focus on inequalities, you need to break down to quite a small population level, because for many of us as the current CCGs, if you take our health outcomes at the level of the CCG, we come across as healthy, affluent populations, but drill down in any CCG areas, and there are significant differences in life expectancy and health outcomes for different populations. And another part of the guidance is how our NHS providers work together. So the removal of some of the requirements for competition for the NHS is a big part of the bill. And how do our providers work together to ensure we are making the best use of all of the capacity available to us to support our populations, delivering across the place, so providing expertise and support to each other. And so what we would like to develop within Bob is have these 3 place-based partnerships, Buckinghamshire, Oxfordshire, Berkshire West, and establishing them in the formal governance term is as a subcommittee of the board, because that enables us to delegate financial decisions, decision-making, accountability to that level, to work with our local authority, trust partners and our local populations. So showing this in a fairly simplified picture, at the right-hand side first is the system side. So there will be the integrated care Partnership and the Integrated Care Board. And we see those being mirrored at place by the health and wellbeing boards that currently exist and continue to have a role under current legislation, and supported by the place-based partnerships, who can take both delegated functions from the Integrated Care Board, but also work on local priorities. Underneath all of that, there is each of the individual organisations needs to have its governance structures, and then at the far side, both on the left and right, a reminder that as an NHS organisation and an NHS system, there's some system oversight and scrutiny applied to us, and at place that would still be the scrutiny arrangements in place within each local authority area. The five local authority areas have agreed that where appropriate, there will also be a BOB scrutiny arrangement for things that affect the whole of the population. And then the NHS is, of course, also subject to oversight by NHS England and the Care Quality Commission. And then just very briefly, talking about the focus for today. So that's very high level. And what I will say, and I know Izzy is on the call, is we have just been able to launch and publish our engagement microsite with where we are keeping together all of the information about the journey we're on and the development of the ICS, and putting some of our key documents. So we are required to have, as an Integrated Care Board, a constitution, and there is a very early draft of our constitution on that engagement microsite, which you're more than welcome to look at. Again, much mandated by NHS England, so only some flexibility in terms of bits that we do. That will be updated relatively soon, but we've also put other information about our journey, and that's part of our approach to try and ensure we put as much in the public domain as we are able to. So this is just a quick introduction from me, and John will talk about it now. Obviously, part of the work we're doing is bringing together 3 CCGs who have had different approaches to communication and engagement. So that's both how they're supported and the ways in which they do it. So one of the bits we want to focus on, say John will talk more about, is a single comprehensive strategy for us as an Integrated Care Board as part of the wider integrated care system. And what's important to personally to me, but absolutely to what we're trying to develop as the organisation, is it should be embedded in everything we do. It should be about talking to the right partners, the right voluntary sector organisations, groups of patients, our primary care networks, our patient groups around particular issues, so that nothing is fed up for decision making unless it is rooted in that, what do people think about what we're saying, so that we do engage effectively and appropriately, and how do we establish multi-way communication and transparency. So we've all learned a lot about how much we can use digital media over the last 2 years, but we also need to remember those that don't have access to some of those digital tools, but also when being face to face or having those individual conversations make a difference. And that's where I was going to pause, so I will take this down.
Thank you, Catherine. Would anybody like to ask Catherine any questions? Like to raise your hand if you have a question, or put it in the chat. No, great. Okay, well, I'm going to hand over. Thank you very much, Catherine. Those slides will be available after this webinar. So, and Catherine, obviously, you'll be available for any other further queries that sort of people have in the coming days, weeks, and months as well.
Yeah,
John Kemp had his hand up.
Oh, sorry, didn't see that.
Sorry, no, I couldn't find the I put my hand up, but that's fine. Yeah, I just had a really quick question, Catherine, around the health and wellbeing boards. And you mentioned that each place would have their own health and wellbeing board, which then feed into the ICP. I think that's right. My acronyms, I'm just trying to work those out. Do you see each of those health and wellbeing boards working as they already do, having their own strategies, having their own kind of ways of working, et cetera, or would you see there's some kind of bringing them together or having some kind of consistency with them to make sure that they're kind of, there's an equal, you know, between the three areas, or is that all sort of still to be decided or talked about?
That's still to be talked about. And also, so there were 5 health and wellbeing boards because they're committees of the local authorities, and they are set up under existing legislation, so they will need to continue to do what they currently do. But certainly the discussions that have started with local authority partners and health and wellbeing boards is the, you know, are the changes in ways of working or things that they want to cover that would be helpful in terms of developing that joint working and that strength at both place level and system level. And we are, you know, not the most complicated, but one of the more complicated integrated care system areas by having 5 local authorities.
Brilliant. No, that's fine. And I suppose, as you said, that it will develop and evolve as the systems do. Yeah, that's great. Thank you for clarifying. Thank you.
Thanks, John. Dave Butterworth, you put your hand up. You're on mute, Dave.
Yeah, I've just discovered how to unmute. This is a bit of a teasing question because one of your 4 objectives, if I remember it, was about productivity and efficiency of delivery. But from what you said, we've just taken what we had before in terms of the CCGs and what you're now calling places, and putting another layer of bureaucracy over the top of it. So convince me that this is a good idea. Sorry.
Well, I will partly say it's not entirely my job to convince you. This is you know, government policy and legislation that but I can say to you that actually, as the 3 CCGs working together ever more closely together over the last year, 18 months, and I can say particularly for my area, we have reduced some of the bureaucracy because we are not having 3 meetings with lots of people in where one would do. I think the bits about collaboration, not competition, not procurement, not contracting systems in the same way, particularly the NHS, reduce a lot of capacity and innovation. And also that bit about how do our local providers work together with local communities, NHS providers and voluntary sector and other providers to deliver services better. And there are kind of current examples of that in many of the patches that are almost happening in spite of rather than enabled by the legislation. So I think it will help. But you know, I'm a governance person that is about form follows function and it's effective and streamlined, and we don't make it over bureaucratic, but we're clear about what's being done, where it's being done, and who we're doing it with. But in other ways, the essence of your question, the NHS reorganises itself a lot because it can't decide whether small is small and that really local stuff is the right way to go, and or when do you add benefit by being at scale. And that is absolutely fundamental in the conversations that we're having, is when does us working at the BOB level have the added value? So what do we do once, say, really good provision of information and data about our population and outcomes, but drilled down to show some of those inequalities, done once would be right, but actually what needs to be done to address those inequalities? What do we need to change? Who do we need to work with? How do we need to work differently? Needs to be done locally. And that's the better. So the benefit is added by working in partnership at place or a different level around a local community. And we've got to continually challenge ourselves on that. But I take the points you've made.
Thanks, Catherine. Gonna take a question from Geeta.
Quite a simple, quick one, but what would you say were the biggest barriers to health and local authorities working together right now?
I mean, if I take our particular geography, it's the three very different kinds of local authority setup we have. So we're Buckinghamshire unitary at county level, Oxfordshire two-tier setup, county council and district councils, and then three unitaries in Wokingham, so needing to work differently. There is, of course, the different funding regimes that we work under, and the principle of health available to all in need for at the point of delivery means testing in some of our local authority services, and the really three, I know, the different organisational setups. So I've been talking a lot with the health and wellbeing boards across all of them at the areas over the last few months, and that, you know, the role of councillors and the elected democratic representative versus an NHS structure based on corporate organisations and statutory boards. But I also think all areas think there's lots to build on from the work that we have done over the, I mean, from before, but particularly over the last couple of years, working in partnership to support population. And, you know, the vaccine programme is an excellent example about local authority support to NHS just to get it set up and run it, but particularly when we were focusing on, yeah, the inequalities in vaccine uptake and how do we work together. Local authorities have really good links in local neighbourhoods, so we need to look at the things that work and build on those. So I hope that answers your question, Geeta, and helps.
Yeah, I would just say that from my experience of working in the voluntary sector, what we often find is that we are actually pushed from pillar to post between the two organisations and told to, if we go into one, told to go to the other, and actually in between. So I just wanted to make sure that was.
So that's a really helpful comment, because actually that's, I think, you know, that really gets at the essence about what this legislation should enable us to do, that you don't get pushed between, as we say jointly. This is the right thing for our population with our statutory sector, you know, funding and support, and it, you know, doesn't matter which one of us is leading. This is the right thing to do, and it's one conversation. But, you know, I also accept we've probably got quite a few steps to go to get there.
Thank you.
Thanks, Geeta. Thanks, Catherine. John, would you like to ask another question?
Yeah, it's just really quick. Sorry, I'm not going to take all the time. It was just about kind of fundamentally, if we're engaging and influencing as the third sector into the ICS, what are those main routes? So obviously we've got to go through health and wellbeing boards or via health watch reps that might sit on those boards, and obviously maybe through local councillors that sit as well on those boards. But is that, from fundamentally, would that be the VCSE's kind of representative on the top table, as it were? Will it be via other avenues? Will it be, or will there be someone on the ICB from the third sector specifically?
So in governance terms, but you were beginning to preempt the next presentation, which is about how you engage and influence.
No problems.
So it is not proposed there would be anybody on the board of the ICB, but certainly the discussions about the integrated care partnership and the guidance on those includes the guidance on working with the VCSE sector, is certainly opportunities to have members on the integrated care partnership alongside local authorities, the ICB, health watchers. But we're, you know, that bit of the conversations barely started because we needed to wait for our chair designate to be in place, but also, just again, in formal governance terms, it can't be established until there's an organisation to establish it.
Brilliant, thank you.
Thank you. And I think that question nicely dovetails us into John's presentation. So thank you again, Catherine, for fielding those questions. And I'd like to introduce John Underwood from the ICS. It's all yours, John.
Well, Rachel, thank you very much indeed for that kind introduction. And let me first of all thank you and colleagues on the call for inviting us to Catherine and myself to give these presentations today. I should explain, I don't work for the ICS. I do a couple of different things, but in this context, I'm the director of the Centre for Health Communication Research at Buckinghamshire New University. And in addition to that, I work with a number of NHS organisations, including some of the ICSs, helping them to develop their plans and their thinking around communications and engagement. And my colleague Steve Davidson is on the call with me today as well. We're really supporting Catherine, who is very much in the lead on communications and engagement for the entire ICS. So that's my kind of background. And this presentation, which I'm about to go through, and I will share my screen in a moment, this presentation is really some very provisional thinking on engagement and involvement. And as Catherine said in her presentation, nothing is yet set in stone. This is very much initial thinking. And what we're looking for here is we're looking very much for your views and your views on anything that you think you feel we should emphasize, anything that you see in the following presentation that you think is wrong, anything you don't see in the following presentation that you feel you should see. So I think that's a few words by way of introduction before I actually dive into the presentation. But let me now see if I can share my screen properly. I think that's the right one to share. And can I just double check, does everybody see that screen now?
Yep, that's perfect.
Okay, very good, very good. So let me just move a couple of things around in my screen here. Very good. So let me begin, if I may, right at the very, very beginning and just raise that kind of question, which is, why do we engage at all? Well, there are many reasons why the NHS and local government needs to engage with its various audiences, but principal among them is that it has a statutory duty to involve patients, the public, staff, stakeholders, and so on in everything we do. But that's not just, it's not just a kind of a legal requirement, as it were. NHS organisations around the country have found over the last few years that it's really good practice to actually engage properly with communities and with stakeholder organisations and so on, and that involving communities and stakeholders in the development of options and plans and ideas and thinking helps to ensure that services are robust and they meet the needs of local people in a real and proper way. And really it's summed up rather neatly in this quote from NHS England, which says, early involvement with diverse communities, local health watch organisations, the local voluntary sector is essential. And early involvement will give early warning signs of issues likely to raise concerns in local communities and gives health commissioners, the NHS, time to work on the best solutions to meet those needs. So that's a really kind of fairly crucial sort of little bit of background as to why we engage with all the stakeholders and communities that we do engage with. And there are some questions here, that are important to consider at this stage, which are, what are the benefits of engagement? Well, you can see some of them here. It's all about encouraging greater public understanding, participation, goodwill. It's about increasing public awareness and education about NHS services and about health generally. It's about developing services that meet the needs of local people. But it's also about obtaining a rich array of information, a rich kind of vein of information, if you like, that helps support service planning and make sure that the NHS becomes better and better at planning local services. It's about improving health education and health outcomes. And it's about supporting the reduction of health inequalities in things like outcomes and access and so on. So who precisely is it that we should be considering that we should engage with? Well, clearly, services are better when staff and particularly clinicians have been involved in their development. So clearly we need to engage with doctors and with nurses and with therapists and other NHS staff. Obviously, I hope it goes without saying that service users, patients, the general public are a very, very important area of stakeholder value here. And this includes things like patient groups, interest groups, the groups that represent protected characteristics and so on, and engagement with groups which sometimes used to be called hard to reach, but I'm not sure that's really quite the right phrase these days, because it's not necessarily that these groups are hard to reach, it's that they're seldom heard, that we don't do enough to reach them. But they are obviously important groups that we need to be able to get to as well, and that includes those living in deprived areas and members of minority communities and so on. But alongside these kinds of groups, there are also political stakeholders. There are MPs and councillors, and we need to, in addition, we need to engage with a whole raft of regulators. And again, as Catherine was saying earlier on, forgive the three-letter abbreviations and so on, the alphabet soup, but there's NHSE, which is NHS England, there's DHSC, which is the Department for Health and Social Care, there's the CQC, the Care Quality Commission, a whole array of kind of regulators and inspectors that we need to engage with as well. And of course, there are our partner organizations within the ICS, and that includes organizations like Health Watch, the array of organizations that are represented on this call today, local charities, and so on and so forth. And it's worth saying a few words about the kind of the principles, the very basic principles of engagement and so on. Here's what we're beginning to think about currently as the basic principles for the Bob ICS. But as I said right at the very beginning, we'd be very keen to hear your views on this as well. Key principles, I think, are as follows. We need to embrace the local knowledge and skills and experience of people in their local communities. And of course, and again, as Catherine said, this is one of the most complex ICS geographies in the whole country. Others seem more natural, but this one has a complexity about it. And so we need to understand that there are different communities within the Bob ICS, and we need to embrace the knowledge and understanding from those different communities. We need to adopt a real and genuine approach to co-production. But I've sometimes been criticized for adding in the bit in brackets here, where possible and where appropriate. Co-production is always important, but everybody needs to understand that there are certain things that are statutory requirements. And so, for example, the kinds of issues and the kinds of ideas that are explained in the NHS long-term plan are not something that are negotiable. They are part of national policy. And so it may be entirely appropriate and entirely proper to engage with people and to adopt a co-production approach on how we develop those priorities, but the priorities themselves are to some degree givens. We should also, another basic principle I think is that we should utilize and adopt digital and non-digital channels of engagement. That seems to us to be very, very important. We've learned a lot about digital engagement during the pandemic, not just in the context of healthcare and health communication and engagement, but in all sorts of other contexts as well. But it's something that I think we now need to build upon and use very, very effectively. We also need to adopt qualitative and quantitative engagement tools. So it's not enough just to do a survey and get an answer that 57.3% of people think this and 24% of people think the other. We should be talking to people as well and engaging qualitatively with things like focus groups and so on. But there are some other key principles as well. These are key principles of good communication, as it were. Our style of engagement communication should be all of these things here. It should be clear and concise. It should be easy to comprehend. It should be jargon-free and expressed in plain language. When, for example, we use TLAs, or three-letter abbreviations, we should always say exactly what those three-letter abbreviations are and what the long form of the abbreviation is. Our communication should be available in different languages and different formats on request. Anything that we do should not be excessively long. Communication in the biggest, broadest, widest sense of the word throughout this country, indeed throughout the world, is becoming shorter and sharper and more focused. And our communication should not be excessively long either. And if we have good communication materials that are short, sharp, and to the point, but which perhaps for some people require and need a great deal of additional information, then that detailed information should be made available, and should be made available separately, and should be there to support the short, sharp, simple communication. I think it's also worth saying a little bit about the so-called ladder of engagement, which I know many of you will be familiar with. This is a participation ladder, which is based on the work of Sherry Arnstein from some years back now, but which has been very much adopted by NHS England. And we should always be seeking to ensure that all of the engagement activities that we do move as closely as possible to the involving, collaborating, devolving end of that spectrum, because that's the way, that's where real, genuine engagement actually takes place. I'm going to say a few words now about the existing guidance that we'll be working towards. The key big fundamental new document is called Building Integrated Care Systems Everywhere. I commend it to everybody. It's a very good document which outlines NHS England's fundamental guidance about communication and engagement through ICSs. And what this guidance says in simple terms is that people and communities should be really at the center of everything that we're doing. And in effect, it's a call to arms to do engagement properly and thoroughly. We should start engagement early. We should feedback everything, feedback to communities and individuals and groups that we engage with, how their engagement, how their feedback to us is being used. We should seek to understand our community's needs. We should build relationships with excluded groups. This document specifically says we should work closely with Healthwatch and with the VCSE sector. It also says we should provide clear public information at all times. We should encourage the development of the community, encourage the development of assets within the community, organizational assets within the community. We should use co-production and insight wherever we possibly can. We should work in partnership with our people, our local people and our local communities. And we should learn from what works. I think a very good piece of guidance here is what matters is what works. And when we find things that work in our local communities, we should stick with them, we should embrace them, and we should try to use them more and more if we possibly can. But alongside that that big fundamental guidance, which is specific for ICSs, there are a number of other national, regional, and local guidance documents, including these that I've mentioned down here. These are just some of them, but Building Strong Integrated Care Systems Everywhere is the one that we've just talked about. But then there's Planning, Assuring, and Delivering Service Change for Patients, which was revised just 3 or 4 years ago now. Transforming Participation in Health and Care, Planning for Participation. All of these are good documents that each give us something that's very valuable in terms of engagement, and we're planning to use all of those. There's also a good deal of legislation that deals with engagement and consultation in the broadest sense of the word. I won't go into all of the details, but the NHS Act 2006 requires health commissioners to fulfill their duty to consult the relevant local authority in its health scrutiny capacity. The Equality Act 2010 requires all public authorities, NHS organisations in particular, to have due regard to the public sector equality duty when making decisions. The Health and Social Care Act 2012, which was an amendment to an earlier act, also has a number of requirements, makes a number of requirements of NHS organisations and ICSs, by implication ICSs, to engage in particular ways. And the Health and Social Care Quality and Safety Act, the most recent one, also lays down duties concerning the importance, for example, of sharing information. On top of this, there are a whole array of Cabinet Office general consultation principles, which were last revised about 5 years ago, but which again give us a lot of background that we need in terms, and that we propose to take account of when undertaking our developing our engagement strategy. I'm coming towards the end now, so please bear with me. I'm almost there, as it were. On top of all of this, there are the NHS England so-called 5 tests. NHS England requires, in the development of NHS strategies, that there should be strong public and patient engagement. There should be consistency with current and prospective needs for patient choice. That there should be a clear clinical evidence base for our strategies and for any changes that we might be proposing. There should be support for proposals from clinical commissioners. That goes back to what I was saying earlier on, that it's terribly important that clinicians, doctors, nurses are fully behind the kind of strategy and any changes to strategy that we might be developing. And there is also a bed closures test, which NHS England has applied, which in effect requires that the NHS should make a very, very strong case before it closes hospital beds. Not that that's particularly likely at the present time, as we're desperately trying to deal with the COVID backlog, but it's a principle which clearly we need to bear in mind. And as I'm drawing towards the conclusion here, it's also worth bearing in mind that we should bear in mind the gunning principles, which again, I know many of you will be aware of. These are principles that emerged from a legal case in 1985, and they've become important, as it were, case law that everyone has to abide by. And these are principles that suggest that engagement should take place at a formative stage. So it's no good developing a strategy and then engaging. Engagement should take place as the strategy is being developed. There should be intelligent consideration and response. So time for enough information must be put forward for people to be able to give an intelligent response, having given it intelligent consideration. Adequate time should be given for consideration and response. And then, and this is a really, really important point, when the stakeholders, the public, our communities have come back with their views on a particular topic, it's no good just saying, right, we've heard your views, we're now going to forget them. They should be given conscientious consideration as well. I'm now at my last couple of slides, you'll be pleased to know. A couple of final thoughts to share with you. One of the things we are thinking about, and your views on this would be gratefully received, is the idea of whether we should be having some sort of stakeholder reference group or groups to help us, in a sense, to ensure that there is appropriate stakeholder, staff, service user involvement in all of our engagement activities. And there's a big question here about whether this should be ICS-wide, or what an ICS-wide reference group, or place-based reference groups, or whether these should actually be project-based reference groups. And I'm not suggesting that we have an answer to that at the present time, but any thoughts from the people on this call would be certainly gratefully received. Clearly, the membership of that stakeholder reference group will be something that we need to think through and discuss. But we're thinking that members of that stakeholder reference group are going to be encouraged, we hope, to bring the views, the knowledge and the experience of their communities to the table, rather than necessarily their own personal views. So that's a little thought to leave with you that we might pick up in questions in a few moments. Final 2 slides, digital engagement. There's something to be said here about digital engagement, which I do think is important. And again, your feedback would be valuable. The COVID crisis of the last couple of years has really demonstrated how the NHS can respond in a magnificent fashion when faced with an emergency. In addition, it has shone a really, really harsh light on the need for change in the way we deliver health and care. And it has driven a whole new way of dealing with healthcare, new forms of healthcare delivery, and new forms of engagement as well, including a whole range of digital channels. And I think it is important that we should embrace and use these fantastic new digital channels, but always remembering that some people are digitally disengaged, and we must not allow that group of people to be left behind. The digitally disengaged is actually now a very, very small group, but they must not be forgotten, and we must bear them in mind. And I think this is my final slide. Yes, the final slide really relates to the ICS role. However we do engagement, I think it's important that there is some kind of engagement coordination. All too often, what we have found previously in geographical areas is that there's a bit of engagement about this, something to do with mental health. Then there's a bit of engagement about that, which is something to do with maternity. And there's almost like a sense of, there can be a sense of engagement overkill. So our hope is that this, but if the ICS is able to coordinate engagement within the BOB area, that will help us to establish a real core of best practice. It will enable us to instill a kind of a consistency of approach to engagement. It will ensure a consistent approach to messaging and to feedback to our communities. And it will enable us to make best use of scarce staffing resources, enabling maximum resources to be spent on clinical healthcare. I think, Rachel, that draws me to a conclusion. I don't know, first of all, if there's anything that Catherine would like to add to that. Catherine, can I just quickly double check in with you? Any quick thoughts or additional thoughts that I've forgotten or missed out there?
So nothing to add, but just to say I put the full title of the guidance and the link in the chat for everybody. But then I think it's over to sort of questions and discussion.
Thank you very much indeed. So Rachel, that's it from me. So over to you.
Thank you very much, John. If you'd like to stop sharing your screen.
I will. Just bear with me 1 second while I find out where it is.
I can see somebody's already got their hands up. So John Holt, would you like to ask a question?
I'd just like to make the point that 50% of the clients that we provide for do not have email, and there's quite a few don't have a mobile phone. They are disabled adults in the age range, mainly 60 to 95. So although the numbers who cannot engage digitally may be getting smaller, it's very much a problem with our client group. So I would want that to be borne in mind, please.
John, can I double check which representative group you're talking about and which you represent, as it were?
Yes, I'm a trustee of West Berkshire Therapy Centre. We provide.
Sorry, you broke up slightly. West Berkshire
Therapy Centre.
Therapy Centre, yeah.
Based in Thatcham, and we provide power-assisted exercise for adults with mobility challenges. people with MS, Parkinson's, stroke survivors, people with movement problems, maybe without a specific diagnosis. The age range we provide for is sort of in their teens right through to 100 years old, but mainly they're in the older age range. And it's really quite difficult to communicate with a lot of them. They depend on their house phones, or they even depend on other people getting messages to them. So we just need to bear that in mind.
Well, if I may just pick that up, if I may, Rachel, I couldn't agree more. I absolutely right. And as I said before, you know, this is your particular group that you're alluding to there, but other groups as well absolutely must not be forgotten. What I've seen and sensed in some areas in the past is that, I mean, if I sort of share one statistic with you, the total number of smartphones owned by people in the UK is currently more than one per member of the population. Now, that doesn't mean to say, of course, that everybody has one, but it does mean that there's a very, you know, 90% of people are very well digitally engaged, as it were. But what I've heard in the past is that people have sometimes said, because there is a smaller group of people who are not digitally engaged, we should not do digital engagement. And I actually think that what we should do is we should do digital engagement, which works extraordinarily well with those who are digitally engaged, but we absolutely must not, under any circumstances, forget the kind of cohort of people that you're alluding to, and we must redouble our efforts all the time to make sure that that those groups are considered and fully and properly engaged with as well. So I think your point is well made, and John, there's nothing you've said that I would for a moment quibble with.
Could I make one other point?
Please.
What has come across a lot to myself and my colleagues over the last 2 years is when we meet face to face, the body language adds a lot to the communication which happens, and Zoom meetings can lack that hugely. So Zoom meetings have been incredibly useful, but there's still a lot to be had from face-to-face meetings.
Yeah,
thank you.
Really agree. Yeah, totally agree.
Thank you, John. Jess, you've got your hand up. Would you like to ask a question?
Hi, thanks everyone. Yeah, I'm Jess Walsh. I'm Director of Services for Oxfordshire Mind, also working in Berkshire West. I guess my question really is around picking up on the question you posed us, John. What conversations have been had with the voluntary sector, the NHS and local authorities around the existing groups that there are for consultation, patient and carer reference groups, service user involvement, as we would call it? Because I sort of feel like that's really core to what the voluntary sector does and how we operate, and there's a phenomenal amount of expertise kind of in the room around that, and also a lot of groups. And I know sometimes our service users tell us that they feel a little sort of over consulted, and obviously the principles that you've talked about in terms of making that really genuine and meaningful and being clear on closing the feedback loop and it being genuine and what is up for negotiation and what isn't, is all, you know, our kind of day-to-day work really. So yeah, I guess interested to hear the appetite from the ICS and how we might do that meaningfully without duplication from existing things across quite a complex network of systems and services.
I'm very happy to offer some thoughts on that, Jess. Catherine, would you like to say anything to begin with, or shall I kick off? And why don't you say a few words to begin with? Yeah,
if I could just so Jess, and I think that was, you reflect why I also tried to talk about how important, you know, place and local relationships and current relationships are to us. So we absolutely want to build on what's already there and working, and certainly not into dismantling anything that's working, but equally for you to highlight if we are duplicating, confusing, muddling, and we can release things, and then that conversation about what adds value. So we've not done the detailed conversations or the detailed mapping. We're starting with these sorts of events to say, what is it you want us to look at? So we're building something that works for you. So that's a really good point, and I'm sure John will come in with some suggestions about what we'll do to take it forward.
Yeah, I think it's a tricky balance, Jess, that you allude to, really, because certainly what I've found in other parts of the country is that sometimes there is a kind of a sense of engagement overkill, and I mean, one of the things that does strike me as being really important was the last slide that I threw up, which is the importance of ICS coordination. One of the things that strikes me about ICS is there are many things about ICS that I personally feel are a big step in the right direction, not least of which is the commitment towards collaboration rather than competition. So that does strike me as being an important step in the right direction. But one of the other things that I think we've lost within the health sector over the last few years is that degree of what one might describe as kind of coordination at a level which makes sense. NHS England has 7 big regions, and in some ways those regions are, I mean, they're important, but they're sort of almost like too big to get your arm around. But the idea of just over 40 ICSs feels to me that we're now dealing with the kind of community size which feels about right. And if, you know, it could, because it allows, as much as anything else, because it allows for a degree of meaningful coordination in a whole range of areas, not least of which is engagement. So it feels to me that coordination role is going to be an important part of what the ICS is doing. We clearly need to develop, we have already developed to some degree, a kind of a database, but if we then move on to develop a stakeholder reference group, I'm sure many other people and many other organizations will you know, either want to be involved or will want to be part of that database, and part of our role will be to make sure that we communicate and engage with all of them in whatever form and manner seems to work best and most effectively for them. Does that sort of, at least to some degree, address your question, Jess?
Yes, I mean, it's a challenge and it's a longer conversation, isn't it? And I'm also mindful that whilst there are many of us here today, there are bits of our communities that aren't represented. And on one hand, hopefully we can be allies and voices, but on the other hand, I sort of feel like you can't ask the people who aren't in the room what would work for them when they're not in the room. And I think we should challenge ourselves not to forget about those voices as well.
Absolutely. Well, as Catherine said, this is not the only one of these sessions that we're doing. So we've done others, and we will, I'm sure, do more. So don't imagine that just because somebody's not in this meeting that they've been forgotten. You know, we're working on a very wide array of stakeholders.
Thanks, John. Thanks, Jess. Dave, you've had your hand up for a while. Apologies if you'd like to ask a question.
Hi, can you hear me okay?
Yeah.
Okay. The question for John is two separate questions, actually. The first one is, I would imagine that your slide number 19 is your contact details. That would be useful to see. The second one is just in terms of a definition. On slide 4, you spoke about stakeholders as being MPs and councillors, etc. But when you were talking about the stakeholder reference group, you included everybody. So it's just a matter of who are the stakeholders. I must admit, when you went through slide 4, I was thinking, well, I thought community and voluntary sector were stakeholders in this as well. Just to say, I'm from Community Transform. It's a Bucks-wide charity that specialises in community development.
Yeah. Dave, I'm sorry, I'm going to have to go back and just clarify with you. So okay, first of all, slide 19 isn't our contact details. It's just simply the questions that we were going to raise. Catherine and I will make sure that you get the slides and contact details afterwards.
Okay.
We'll make sure that happens. The questions on slide 19, I'll just read through them. I mean, they're very simple and straightforward. They were, what do we mean by involvement, engagement, and co-design? What are the barriers to good engagement? What are we currently doing well or less well? Is there anything in our draft approach that should be excluded? And is there anything that we should add to this draft approach? So that they were really just questions to kind of kickstart the conversation. But going back to your second point, I think you were asking whether the community and voluntary sector whether we considered them to be one of our stakeholders. Was that your question?
It was just about the use of the term stakeholder. I know a lot of people sometimes struggle with it and sometimes have different definitions of what it really means, because it's used across a number of different sectors and it means different things in different contexts. But you sort of used it twice in a slightly different way. So in as I say, in slide 4, it was, you detailed out MPs and councillors, etc., specifically stakeholders. But then when you're talking about the stakeholder reference group, you included everybody.
Yes, well, if it was confusing, please accept my apologies. To clarify, on that slide where I mentioned MPs and councillors, I did also say that the third bullet point is partner engagement, including Health Watch, VCSE, charities, etc. So definitely our view, our sense, our feeling is that the sorts of people and organisations represented on the meeting here today are absolutely crucial stakeholders in the context of of Bob ICS and the engagement that we believe we want to do and we know we want to do. So there's no question that your organisation, the organisations represented today, we would consider to be key stakeholders. And when it comes to some form of stakeholder reference group, either ICS-wide or place-wide or project-based or whatever, again, no question whatsoever that this group of stakeholders would be key and central within that that as well. Does that clarify it, Dave?
Yeah, it does. Thank you. Yeah, I just like an added comment. I'm really excited by this. You know, working 35 years in community across Bucks particularly, to see this happen is very welcome, because experienced a lot of discontinuity and gaps and problems. So I'm hoping we can get this right and it'll be successful. Thank you.
Well, that's really terrific to hear, because part of whether we can make this success or not depends on a fair wind, if I can put it in those terms, and it depends on people trusting us to be genuine when we say we're committed to this, and look, I'm in a sense an outsider looking in, but I've been deeply impressed by the degree to which Catherine and her colleagues within, who are currently, I might say, doing 2 jobs at the present time, running CCGs and running the ICS. I've been very impressed at the speed and rapidity with which they're moving exactly these kind of questions forward. So it's really nice, Dave, to hear that kind of positive response, and we're grateful for it.
Thank you.
Thanks, Dave. Thanks, John. John, would you like to ask a question?
Yeah, thank you. Sorry, me again. Just a couple of points, really. So I work across 8 for the job I did, stakeholder engagement officer for Sea Rider. So I'm working across 8 ICSs, including Bob, obviously. And it was just kind of, I think obviously we're all coming at this from a different angle, and for our kind of what our jobs are, what we do, we're coming from it slightly differently. So from my point of view, it's around, well, the first bit obviously mentioned around I think engagement, all the stuff you had in your presentation, John, I think is great. And obviously I presume we'd all agree with most of that stuff anyway, but I think the point for me was, and this is going back because I've worked with in the NHS and with providers and third sectors and different people, and worked within engagement and influencing. And engagement's great and it's really important and absolutely necessary, but it's that thing of you know, are we just ticking boxes and making sure it isn't just because, you know, there is that kind of necessity to engage, and how do we do it democratically, and how do we do it kind of, as Jess mentioned, to make sure it's meaningful and it's across the board and we're representing everybody as far as possible. And that's impossible to a point, but as many as we can. So that's the first little bit. And secondly, it was just around the stakeholder reference group that you mentioned and how you would see that working. I think for me, Sue Ryder's got a couple of services that run through. They've got the hospice in Reading and the Oxfordshire Palliative Care Hub. So you look at different services there within two different parts of the ICS. So I think actually to have a place-based stakeholder reference group and maybe individual, so you've got end of life, you've got cancer, you've got all the different things, because I think, you know, the expertise is there, and I'm sure it already exists to a point. There's already groups and alliances within sort of service sectors potentially, so it's picking up on those. I know that our hospice works very closely with the sector in that part of the ICS already, and it's about actually how do you kind of make sure that that voice is being heard at the high levels, not just at the kind of place base, to have that consistency across the whole patch, because you don't, you know, Reading might be served really well with a Sue Ryder hospice, but you might not get it, you know, in a different part of Oxfordshire or Berkshire or whatever. So it's that kind of dual aspect, I suppose, and it's not easy. Absolutely, I get it's a really tough and really difficult, complicated job. So I think it's great to be able to come to these things and have a say, and to meet people and to have that conversation at this point. So thank you for the opportunity as well.
Well, John, thank you. Let me come back to you, if I may, on that second point first. Did I gather from what you were saying that your view, and remember, we're looking for your views here as much as anything else. Did I gather from your view there that a sense of, and I don't want to put you on the spot, as it were, but yeah, but did your sense was that perhaps engagement would be better if it was a little more place-based rather than ICS wide? There could be a role for coordination for both, but yeah, I don't want to put words into your mouth.
Yeah, I mean, it'll probably, you know, be different for different groups, but I think for the end of life, particularly for that sector, I think within each CCG already, I think, as far as I'm aware, working over at ICS, so excuse me if my memory lapses a little bit, but we've got a really strong kind of end-of-life hospice sector alliance or grouping. So we work with our local sector partners already, and it's a case that's just across AC, so one place of the ICS. And I think it's important to maybe have, because obviously going back to the communities served in each of those places is going to change and be different. So I think maybe to have something across a place, and then maybe to feed up into something across the whole of the ICS to ensure that there is that kind of, you know, overarching strategy. There's something that goes through the whole, you know, there's a pathway that covers the whole thing, rather than it be really, you know, someone in Reading might have a different experience to someone in Oxford, you know, just purely because of their postcode rather than, you know, all the rest of it. So I think, yeah, there's probably a opportunity to have both of those potentially. I don't know how easy that would be or how complicated, but yeah.
Well, look, listen, I'm not, I mustn't, I can't commit the ICS to anything at all, but I've got to tell you, that doesn't sound unreasonable to me. I think there's much to be said for that, the kind of structure that you're talking about. Catherine, would you like to add any thought on that?
Yeah, so thanks for that. I think that's really useful point, because I do think there are times when we want to be, you know, engaging regularly around specific areas with those with the expertise. So like you talk about the end of life way, and that might be very local, and we need to be able to support that. We need to support general population discussion, and also we need to have mechanisms that get it up. So I work with the chief executive who talked about it. You know, it's in some ways it's like a lot of Lego bricks. We've got lots going on, and we've got to work together about how we put it together, and we might change how we put it together for different things. So I'm absolutely right. We want to be able to support things in the right place with the right people, and enable them to be able to be heard at all the different levels. And again, it is taking your expertise and thinking it through, because it's also about not tying up lots of people in lots of meetings that we're not clear what they're doing, but it's about how we keep that. And I think they were some of the points I put on my last slide about how we support that kind of free and transparent flow. So any good ideas from anywhere else, given you work across so many ICSs, we are happy to hear, adopt.
Thank you for the thoughts, John. Very grateful. Rachel. You're on mute, Rachel.
Apologies. Okay, Dave Butterworth, you've got your hand up. I think this is the last question, comment we're going to take before we do some summaries and next steps.
Yes, thanks. It seems to be that one of the most important stakeholder groups in all this are the GPs. They're very much on the front line. I just wondered how involved and supportive they are to what's going on. And when I say that, I'm conscious that these important changes are taking place at a time when the GPs just have no time but just to do what they're doing from a day-to-day basis. It's very difficult.
So I can answer that one. It's obviously clearly quite a big change in some of the organisational structures. So clinical commissioning groups were based on member practices and their authority and how we set ourselves up, and all three CCGs have significant GP clinical input to their governing bodies. We have been doing well, actually the local medical committee, with us supporting them, have done a large bit of engagement work with our general practices to talk about, because as you say, they're another stakeholder, another set of providers in this, about how the ICS and ICB could and should work with them, and how they are engaged, and how we ensure that they are appropriately represented in structures such as the place-based partnerships. And also I didn't talk a lot about the governance, but the board of the Integrated Care Board is required to have a member that's nominated and selected from primary care. So we're working through all of that together, and it's a not dissimilar conversation, because there are multiple GPs, multiple practices, very locally based in their village, their town, their bit of the city. They work with their partners in primary care networks, they work in bigger geographies with community services teams, and then we have, they all refer to particular hospitals, so that kind of defines our place. So we are working all that through too. I mean, in terms of whether they like the changes or not, we're not really exploring that. But again, going back to what I said earlier, we are used in the NHS to having legislation that determines it's time for a new organisational setup, and sometimes you have to separate your personal views on that with it's the job that I have to do to make this work. And I think, again, going back to what Rachel said at the beginning, aligning to our common purpose, we are here to enable the best health and the best health services we can with the money we've got for our population, and we can only do that by working effectively within the structures that are the structures of the day.
Thank you, Catherine and John. John Holt, you've snuck your hand up, so I'm going to make this the very final comment, and then we will go to next steps and summaries.
I'd like to put in a plea for carers. The example I'll give is I've been involved a great deal with the MS side of life, multiple sclerosis. The NHS is a minor player in the provision of care for people with MS. Social services is a bigger player. The MS voluntary sector is an even larger provider of support, but its husbands and wives and family and friends provide even more than the voluntary sector. And it's essential to get the views, understand the needs of carers, because when carers fail, which they sometimes do, then the system sometimes finds it very hard to kick in. Thanks for the opportunity to say that.
Thank you, John. I think we can wrap up the meeting here now. What I'd like to just say is that today's event has been really, welcomed. It's encouraging to hear that the ICS response or approach to this is engagement before strategy has been developed, because all too often engagement strategies are developed and then sort of the voluntary sector and people are brought along to do that tick box exercise or to bring additionality when the strategy's already been developed. I think we're in a really unique place, as well as a group as BCSE organisations, that not only are we a stakeholder in our own right, that we are a group of providers working predominantly and largely towards reducing health inequalities and improving health for people in communities, but we also have that reach out to the wider stakeholders that are the communities and people across FOB. So we do sort of have that two-pronged approach, obviously working alongside Healthwatch to providing some of that softer intelligence around people in communities' views and their barriers to health. John, Catherine, I don't know if you'd just like to say a little bit about next steps and what the outcome of these webinar sessions with stakeholders will be, and how you'll take information forward to the next steps and developing your strategy.
I'll start. We are absolutely taking the feedback from all of these sessions into developing what would be a very, very, very first draft of a written strategy, which we would then want to have further conversations and engagement about, and we expect to be doing that over the next sort of month to 2 months and get things. And as Steve has posted in the chat for us, a reminder that we will keep things up to date on that engagement website, and you're also all very welcome just to pop any comments or questions through that. I suppose I've got an ask of you, if there were one or two who or the Alliance wants to go away and think about it, in terms of some links for us to talk to in that early development stage, so that it's informed all the way through. And then we have more things to go out, and or to start providing a core group with us in terms of thinking about those different approaches, and that knotty issue that we've all raised in different ways about how we manage the very local, the very specific, but ensure there are ways for the voices to be heard throughout. So that's kind of where I'm coming from, and my offer to you, but also my ask.
John, have you got anything to add to that?
Well, I think that the only thought I'd add, really, Rachel, is that as Catherine said, there's a couple of requirements upon us. NHS England requires us to develop a written engagement strategy, as it were, and quite rightly so. We should do that. But I think one of the things that we'll be seeking to ensure is that the big fundamental part of this engagement strategy is how we, on a continuing and ongoing basis, get the kind of feedback and engage about engagement with groups like this, like the kind of people that are on the call today. Now, that comes back to things like the stakeholder reference group and how that's developed and how we develop that and so on and so forth. And obviously we want to talk to people about that, as Catherine was saying, over the next month or two. But clearly we'll also be sharing our thinking on the engagement website that Steve has popped into the chat box. So please keep coming back to that. And that's one of the ways in which we will be seeking to feedback and seeking to continuously engage with people. I suppose final thought from me is that even when the ICS gets up and running in the summer of this year, you know, that's not the end of the development of the engagement strategy. We may well have an initial engagement strategy, and it may well be that over the course of the next 18 months, from like where we are now until the middle of next year, that we will be learning new ways of engaging with people, discovering that certain things work and certain things work less well, you know, and so on. And so we shouldn't regard the first engagement strategy as being something which is going to define what we do for the coming 10 years. It should be something which is developed over a period of time. But having shared that thought, Rachel, I think that was probably it from me.
Thank you. I think all that's left to say today is that thank you for everybody to attending. Big thank you to Catherine and John as well for coming along and presenting to us. And look forward to working with some of you or all of you moving forward on this engagement strategy.
So do we, very much. Thank you very much indeed, Rachel, for organising. Very, very grateful to you.
Thank you so much. Very helpful.
Thanks. Bye-bye.
Thanks, everybody. Bye-bye.